Welcome. Welcome, everyone. My name is Dr. Carol Neal, Chair of the Population Health Committee with the National Black Nurses Association. Welcome to Wisdom Wednesdays. Welcome. My name is Dr. Carol Jenkins Neal with the National Black Nurses Association Population Health Committee. Welcome to Wisdom Wednesdays. Today, we're going to talk about kidney disease, and we're going to talk about some of the different changes, some of the different things that happens in the kidney space. We have two dynamic speakers with us today. We have Mr. Eric Vicks. Could you wave your hand, Mr. Eric? And we have Mr. Patrick Gee. Could you wave your hand, Mr. Gee? We have so many people on the screen. Thank you for joining us. Mr. Eric Vicks is a native of Cincinnati, Ohio. He's the director of he's the director of the Patient Advocacy Division of the American Kidney Fund. He has served over 15 years of experience with patient advocacy. Also, he's worked with public health and health disparities. And we're delighted that he's going to be with us today to just share some of the different goals for American Kidney Fund and talk to us about how American Kidney Funds help the minority community. Secondly, we have Mr. Patrick Gee, and Mr. Patrick Gee is a representative of the Diabetic Kidney Disease Collaborative Task Force. He is a transplant survivor, and he's also the founder of iAdvocate. And today he is going to share his personal testimony and his story of kidney disease. So Mr. Gee, could you please open your mic, because I would love for you to be able to share your story with the National Black Nurses Association. Please share your story about your journey with kidney disease.
Well, first of all, thank you, Dr. Neal, and it's an honor and pleasure to be here. My journey with kidney disease began in 2003 when I was at work. At that particular time, I was an institutional training officer, corrections captain in the Virginia Department of Corrections. And I was feeling a bit sluggish, a bit tired, and actually went to sick bay, just to talk to the nurse about, I was feeling very low energy at the time. And she asked me, had I ever had my glucose levels checked? And I didn't know what she was talking about. So, I was like, no. And, so she did a finger prick. And I noticed that she went and got the charge nurse and also called my supervisor. And she asked me to relinquish my car keys. And I was looking at her like, well, why do you want me to give up my car keys? She said, well, your glucose level is 758 and you should have had a stroke. And if you get behind the wheel of your vehicle, I'm going to call the Virginia State Police and have you arrested for driving under the influence because your glucose level is too high. So I relinquished my keys. I had an officer to take me to the emergency room. And it was at that time that they checked my A1C and noticed that it was 11.7. So the emergency room doctor told me, well, Mr. G, you are probably dealing with type 2 diabetes, and I'm going to recommend you to an endocrinologist. So after meeting my endocrinologist, who ended up being my primary care physician, she put me on 2 forms of insulin, metformin, and just told me, hey, you need to lose weight. So now we go 10 years later, April 2013. And after a routine visit with my endocrinologist, I was actually getting ready to walk out of her office into the parking lot. She ran behind me, was like, hey, Patrick, I forgot to tell you that at looking at some of your past labs, you're now at stage 3B of end-stage renal disease. Now, here again, I didn't have a clue what she was talking about, but she said, your kidney function is between 30 to 35%. So I was mad because I was like, well, why didn't you tell me when I was at 75%, or why not even at 50%? And she never responded. All she said was, I'm going to refer you to a nephrologist, AKA a kidney doctor. So a couple of weeks go by and I go to a nephrologist, and the nephrologist during that appointment tells me, well, Mr. G, you're eventually going to go on dialysis, but there are a couple of things that you can do to kind of slow down the progression. And that would be to abstain from dairy products, chocolates, and nuts. So during that time, that waiting period, my kidney function continued to decline to the point that I was actually gaining weight. I wasn't eating much, but because I could not urinate the toxins out of my system, I was retaining fluid. So November of 2013, I'm going to my nephrologist appointment. In between that time, I was unable to sleep. I gained so much weight in that period, about 150 pounds. I really didn't have any clothes to wear. Nothing would fit. I wasn't able to lay down in the bed and go to sleep without choking or hyperventilating and things like that. So we go to my doctor's appointment. My wife is like, my husband can't speak. He's choking every time he, tries to sleep. Doc, when are you going to start him on dialysis? So it was at that time that my doctor called and made an appointment. And at that time, I chose to do peritoneal dialysis, which is a form of home therapy. So I had the surgery to get a peritoneal catheter placed in my underbelly. And December the 1st, 2013, the same year that I was diagnosed, I did my very first exchange of peritoneal dialysis. So from December the 31st to January the 1st of 2024, I lost a total of 57 pounds of fluid. My kidneys continued to fail. I had some urine function, but 2.5 years prior to my transplant, I was in complete stage 5 of end-stage renal failure. So April the 21st, 2017, is when I got my new kidney. And that journey was very interesting because when I woke up from the transplant, my doctors told me that my kidney was not functioning. They said that I was dealing with delayed graft function. So I had to do 24 hours of dialysis every other day. And in between doing dialysis, 5 days after my kidney transplant, I had a blood clot in my neck, so I had to have another surgery. 3 days after the blood clot surgery, I was hemorrhaging, so I had to have another surgery. 17 days later, after hemorrhaging, they wanted to perform a laparoscopic peritoneal window so I can drain internally, yet my kidney still was not functioning. So after 4 surgeries, 33 days in the hospital, another 6 days in a rehab facility doing occupational and physical rehabilitation, I was finally able to go home. And it wasn't until the 47th day after I received my transplant that one drop of urine came. And it was at that moment that some of the things that we take for granted really hit home. So it was after that, moment that I knew that I really needed to become more of a vocal advocate to be able to help people to avoid some of the pitfalls that I actually went through in my particular kidney journey. And this is how I became an AKF ambassador, as well as a certified kidney coach. So now, as an ambassador, as a kidney coach, I've been able to go out into the community all over this country, even by way of Zoom calls, to go internationally and to not only teach those patients, care partners, certain support systems in churches, social civic organizations about kidney disease, but I also talk about health equity and some of the other projects that the American Kidney Fund is currently doing. But then where it really became personal was 2 years ago. My second to the youngest son, Quentin, went into kidney failure. And he is currently 2 years into in-center hemodialysis. And he was recently tested for APO1, and he tested positive. So with him testing positive for APO1, a rare genetic predisposition, he now deals with FSGS. So when I think about myself dealing with diabetic kidney disease and my son with a rare genetic predisposition with kidney disease, then I have a daughter that is living with lupus nephritis, kidney disease, and everything that surrounded it, including the comorbid conditions, has now become my ministry. It's now become my job to somehow find a way that we can certainly not only find innovations and therapies, but to also find a way to eradicate kidney disease. So that is my story in a nutshell.
That is an amazing story. And I think it's great that in spite of everything you went through, you were able to come up with a way to be able to become an advocate for others and to be able to help others find their journey. Because a lot of times people are facing different types of challenges, but they don't know that we have organizations like the American Kidney Fund that actually a grassroots organization that could help them. So thank you so much for sharing your story. And we will have questions at the end of this presentation. I'm sure there's lots of members of NBNA that has lots of questions for you. So that takes me to Mr. Eric. Could you please tell me, someone like Mr. Gee, how does the American Kidney Fund help someone in his situation with all of these different challenges? How does your organization help a regular individual with kidney disease, specifically in minority communities?
Thank you for allowing me to join you today, Dr. Neal, and my board member, Ms. Ash Goins, as well. We get people from different ways, and it depends on the person's needs. So some people come as advocates, like Dr. G, because they really they know the troubles and trials and tribulations that they face coming into this kidney space, and they want to make sure it's better for the next person. And so for people like that, we try to develop tools so that they can go back out into the community and provide that assistance to whoever is coming behind them. We provide education, we provide, for some people, help with staying in care. When you have kidney disease, you may have been trained all your life for a specific task and duty, but you find that when you're in dialysis, you no longer can perform those duties. So a lot of people, they're trying to figure out, okay, how am I going to make it to tomorrow? How do I handle insurance? We provide insurance for folks who can't afford to pay for their own. We provide education. We provide resources when people are in dire straits. But I think the most important thing is we help people understand they're not alone. So we do provide community. in a variety of ways. We have our social media, like everybody else does. We try to have events where we connect people to individuals who are experiencing similar issues as themselves. And we try to connect them to policymakers who really need to understand the walk that some of these members have gone through to get to where they are, just to help them understand that these are serious issues that impact the way a person lives and works. But I wanted to share a presentation today about AKF, the American Kidney Fund, and some of the things that we do, and then hopefully we can get questions after that. Bear with me while I try to share my screen here. And I do know that we're going to be kind of squoze for time, so I'm going to try to be quick, but please bear with me. So first of all, our beginnings. We did start simply because there was one woman who had trouble trying to pay for her dialysis care. She found that she was in kidney failure and she needed dialysis care and she couldn't afford it. And so her community came together to help her pay for that. And in the process of doing so, oh, this is back in 1971, the slide says. In the process of doing that, the community was so geared up in trying to make sure this happened. They found they had enough money to help 79 people, not just one. And that was the beginning of our organization. And we've been fighting for over 50 years now to keep that process going to make sure people can stay into care. Our vision is a world without kidney disease. That's what we're working towards. I know it seems a long way off, but we're getting closer every day. And our mission is fighting kidney disease and helping people live healthier lives. So that's the real work of AKF, the American Kidney Fund, trying to make sure we do everything that we can. And we do this by hearing what the patients' challenges are, what their needs are, and we try to address those things. And when we find that there's something that a lot of people have in common, we tend to work on those issues. And it's a lot easier for my department, which I'm working in government affairs, to do, because we can look at policies that address those concerns. And just so that everybody knows, Black Americans make up just 13% of the population, but 35% of Americans with kidney failure. And excuse me, my screen is a little funny here. There we go. We also know that Hispanic and Latino people are 1.5 times more likely to develop kidney failure than non-Hispanic white people. And also, we know that Black people are less likely to be either informed about transplant options or to receive transplants. And this is for a variety of reasons. Some of it connected to the medical infrastructure and some of it connected to just policies that people put in place that disparage people of color. So one of the biggest things that we do, and one of the things that we're known for in many circles, is our financial assistance programs. We provide low-income ESRD patients with financial assistance to ensure that they have access to the services that they need to stay as healthy as possible. We do assist 1 in 6 dialysis patients nationwide, and we make about 100 transplants possible each month. 7.5% of all kidney patient transplants in the US are affiliated with our programs. Grant assistance eligibility. So for the programs that we have, qualified patients will have up to 500% of the federal poverty level income and have liquid assets up to $30,000. As you see, I am getting dyslexic today, I'm sorry. Including your retirement incomes. People who are already participating in low income programs such as TANF or HUD or SNAP, those people are already pre-qualified for our programs. Our safety net program is a program that provides up to $200 per person once a year to make sure that people can stay into care, and they can be for transportation to dialysis, lodging if you need it, transplant workup, because there are some associated costs with that aren't covered other places. And each person is eligible to receive this up to once a year. People in Maryland, Virginia, and DC, they have a separate program, which is still similar, but it offers up to $250 per year for the grant. And again, these are just safety net grant programs, and to help people get over those small humps as they're approaching them. We do have a disaster relief program, and our disaster relief program is triggered when, of course, there's a disaster that's declared in any particular state, and the affected impact area is shared with the American Kidney Fund, and we will do fundraising specifically for that disaster to make sure that people can stay into care. And again, these resources can be used for shelter. They can be used to make sure that someone can receive care when they're moved outside of their normal place of residence. For instance, if there's a hurricane, that's usually the example we use. A lot of times people have to leave the area that they live in, and they find that it's difficult to get care where they are. So we try to make sure that it's possible for people to stay into dialysis care if they needed to, or if there's any medications that they need to purchase, we make that possible as well. Our largest program is the Health Insurance Premium Program, or HIP. It was established in 1997. We actually have the first advisory opinion from the Department of Health and Human Services. That's why it's 9701. That's the first one that they've ever done. And it allows us to provide resources to individuals to make sure that they can have insurance if they could not afford it on their own, so that they can stay in the care. Because these patients, if they are not able to stay in the care, they simply will die. That's the only option. And applicants for the HIP program, they have to be US residents or live in the territories. They receive regular dialysis treatment for ESRD, end-stage renal disease, in the US or its territories. Patients receiving dialysis for acute kidney injuries. So if it's not end-stage renal disease, they're not eligible for it. And this is usually triggered. When you have end-stage renal disease, you also automatically qualify for Medicare. And but in some areas, the Medicare itself will not give you the care that you need to stay well. And so it could be that you can't find a physician who takes the Medicare in your area, or you just may need additional services that are wrapped up within a third-party health insurance program. And when someone does participate in the health insurance premium assistance program, we do not dictate where they go for care. We do not dictate which health insurance that they use. All we do is take the application. The person fills it out themselves, their caregiver, or someone who is a renal professional fills out the application. And we just make the funds available. We don't dictate where they go for care. We don't dictate how they get care in terms of which products they use for insurance either. And if you know someone who is in need of health insurance premium assistance, please have them contact us through our website, kidneyfund.org. And there's a grant management system also that can be found at gms.kidneyfund.org. So one of the things that we do is try to address health disparities in kidney disease. It's one of the major pillars of the work that we do. So all of the work that we do is inclined and geared towards making sure that there's equity across the board for everyone facing kidney disease, which in many cases means ensuring that people of color receive the services that they need to get the best known outcomes. Kidney disease, so one of the things that we get funding for is maintaining our Kidney Disease Health Equity Coalition. They advise us and provide development advice on our health equity initiatives. You are all eligible to join our Kidney Disease Health Equity Coalition. It's usually maintained by organizations, not individuals. So it would probably be the organization that you work for, your office. We also provide health equity trainings virtually and in person. So far, we've been to Georgia, Pennsylvania, and Texas. We've done a virtual one in Virginia, and this weekend we will be in South Carolina. So if there's anyone who's in the Columbia area who would like to join us, please reach out to me and I can make sure that you can get the address of where we're going to be there. We also have a health equity microsite. It's known as Kidney Health for All, and that serves as a comprehensive communications information hub, providing information for folks to understand the disparities around kidney disease. And we provide promotional and media relations for partners who are engaged in kidney health, who also are concerned with the health equity piece. If someone is looking for information or want to have information created to talk to specific communities of color, if they can reach out to us, we can make those available as well. So one of the things we do that's outwardly facing is create webinars for patients as well as caregivers. We have videos as well, and we have Kidney Kitchen. We've created this because many people who have kidney disease, they find that they crash into kidney disease. Like Dr. G had mentioned earlier, where you just find out that you have kidney disease and there's no real warning. When many people are in the emergency department and the doctor tells them that they have to go on a dialysis, they tend not to hear anything else. So even though they might be someone to talk to them about their diet and dietary requirements, a lot of times the patients don't listen anymore. And I know that's something that many of you have already experienced. So we have Kidney Kitchen, which we work on with chefs, professional chefs who've created over 500 recipes, which are kidney friendly. Again, I mentioned before, we have printed materials. We create and we duplicate any materials. You can go to our website and download anything that you need. And if you find that you're having an event and you need more, please contact us and we can have those created for you. The Kidney Health Coach Program, I know Dr. G also mentioned this program. It's a self-guided program that teaches individuals how to talk about kidney disease and how to educate people on kidney disease as well as educate yourself. It's really designed to prepare people to be advocates in the community so that they can talk to their community members about kidney disease, what's needed, what they can do, the truths and myths are debunked in this particular program. It's self-guided. And once you complete the program, you do receive a kidney coach kit that comes with a t-shirt. It comes with materials to help you facilitate your discussions in your community. And let's see. Sorry, my computer seems to be. Oh, there we go. Continuing education. American Kidney Fund provides continuing education credits, and these are online courses for dietitians, social workers, nurses as well. We have topics on disease management, best practices, comorbidities, and psychosocial care. One of the major pillars is research. We do have clinical science and nephrology. So this is our fellowship program. We've had over 40 fellows that have come through this program and have started their careers with the American Kidney Fund. The Unknown Causes of Kidney Disease Project. So just again, so that you know, most diabetes can be, excuse me, not diabetes, most kidney disease can be attributed to either diabetes or high blood pressure. And there are over 150 kidney diseases that are known that cannot be attributed to either. And so we are still pushing for additional research and care so that we can determine best practices to diagnose and treat these other unknown causes of kidney disease. And finally, advocacy. I work in the advocacy department, and just so that you know that we do work on legislation at the federal and state level. We have 2 separate teams that do this. And although they do mirror each other. And so some of the major legislation that we work on is the Living Donor Protection Act, the Medigap Support Act, the Kidney Disease and Research and Treatment Act. And we do tend to support all kidney-friendly legislation, as well as we work with policymakers to reshape legislation that we feel would be detrimental to kidney health. And if you want to get involved with us, we have an AKF Ambassador Facebook page, or you could pull out your cell phones and text the word kidney to the number 52886 to join our text alerts, and that will put you in our advocacy network. And you would receive updates from us, newsletters from us, and you would receive action alerts. So whenever there's legislation, either federal or in your state, that your voice would be helpful to pass, we would send you those messages. And it's basically a 2-minute sign up when you first get started, and after that, you'd be able to send messages in less than 1 minute. And we also refer new members to join the AKF Advocacy Network, which is reachable on our website, kidneyfund.org. That's what we do in a nutshell. I know there are some things that were left out, and I'm looking forward to answering any questions you have. Thank you.
Excellent presentation. Thank you so much, Mr. Eric. So I want to open the floor now for anyone in the audience who may have questions. And prior to that, I'm going to go to the chat line because I'm sure we probably already have some. So Tanisha Leonard says, awesome story and journey, Mr. G. Being an advocate is so important for this population. It hits differently when someone who has it in their shoes and they also share the story. And I agree with her. When you have an ambassador and they are living it and they are going out in this community telling the story because they can feel it because they experience it. I think that's a good thing. Miss Leonard, is there anything else you would like to add to that in a question form? Okay, I guess not. I'm going to go on to the next person. And the next question, Dr. Martha Dodson. Good question. She says, although we cannot get a mini clinic in our neighborhoods for preventative care and health promotions, you can always find dialysis treatment centers or health promotion, protection, and prevention. So what can we do to prevent end-stage renal disease? Could you take that question, Mr. Vicks?
Actually, Dr. G would be better for it, but staying in care, honestly. We recommend that people see their primary care physicians regularly. We also recommend that they ask their primary care physicians to test their kidneys. So in the early stages, the test is a urinalysis. That's how you can detect, I think, stage 1 and 2. And if I think the later stages, it's a blood test. But it's a simple test. It's just that if you don't have those pre-existing conditions of hypertension or diabetes, most of the time their doctor doesn't want to do it. And so I have come across patients where they've expressed that it has been a fight to get their doctors to actually give them that test. But we do still strongly urge our members and their community members and families to talk to their physician, get the test, request it, request the results, and actually have them sit down and talk to you about what those results mean.
Thank you. Mr. G, you said something interesting. When you first went to the doctor, she told you not to eat, I think it was chocolate, nuts, and something else. What was the third thing?
Dairy products.
Dairy products. Okay. What would be your advice for us or anyone? What would be your advice on preventing end-stage renal disease? What would be some of your preventative measures that you would share?
Well, my biggest takeaway is health literacy. When you think about health classes being taught in elementary, middle, high school, and even colleges, they never teach anything on kidney education. So that would be a first start. If you are in an at-risk group, so just like Eric mentioned, if there's a family history of diabetes or hypertension, you also have to look at a person's age. You have to look at a person's ethnic background. So if you are Black, African American, if you are Alaskan, Indigenous, Native American, if you are Hispanic, Latino, you are at risk of kidney disease. Also, if you are a smoker or consume more alcohol than needed, it puts you at risk for kidney failure. If your diet isn't in line, if you eat a lot of food that contain sodium products or processed foods, it puts you at risk for kidney failure. So there's a number of things that can literally put you at risk. And even now, as I mentioned with my son, it can be hereditary. So I would just advise people that fit into those particular criteria to really have that discussion, just like Eric said, with your physician, and be very adamant about it. And here again, just like Eric said, it's just a simple test. It's a blood test and a urine test. And it can tell you if you are at risk. And if you are, I would certainly talk to your primary care and see if you can be referred to a nephrologist or a kidney doctor so that they can literally monitor that.
I have a question. Could you talk? You said you were, by the time you were diagnosed with kidney disease, you were at stage 3B.
Yes.
Is there, between the both of you guys, could you guys talk to us about the different stages, how many stages there are, what happens at the different stage? And I think you said at stage 3B, you were at 35% functioning of your kidney. Is that correct?
Yes. So there are 5 stages to end-stage renal disease. So now everybody in this country know if you have what's perceived as normal kidney function, you are at 90%. So that would be anywhere between 100 to 90% kidney function. I believe stage 2 may be anywhere from 89 to
60.
probably 70%. When you get into stage 3, there's a stage 3A and a stage 3B. When I was diagnosed, as I stated, I was at stage 3B, which right in that particular area is between 30 to 40%. Stage 4 is anywhere from 29 to 20%. Stage 5 is anything below 15%, just to 0. So normally, when you go on dialysis, normally nephrologists try to wait until you are close to 15% kidney function as possible before they start you on dialysis. So there's a number of folks that can live normal lives at stage 3B, and some even at stage 4, and never go on dialysis. But it just depends on when it's caught. And normally when you talk about African Americans, normally we tend to crash into kidney disease because of some of the medical misconceptions, like, you know, we have tougher skin, or we have thicker bone structure and stuff like that, which can kind of be a barrier when it comes to detection of kidney disease.
That's really sad in this day and age. Talk to me, Eric, about HR 5027, about that bill for improvement with kidney disease. What's happening with that particular bill?
Okay, chronic disease improvement and
Chronic
treatment
kidney,
act.
yes, that's it.
I'm sorry, let me get my bearings here, because there was a bunch of them that just came through real fast.
Yes.
This one actually is looking at making sure that we have an understanding of how to treat these kidney diseases. So again, this is one of the things that goes with one of the rare kidney diseases, because right now there are no patent ways of treating and detecting. And
Yes.
we're requesting that, I think it's HRSA, is it HRSA? HRSA and the FDA will come up with language and metrics to first test people for the rare kidney diseases, and then come up with protocols for treating. Right now, they don't really exist, so you can go anywhere and anybody can come up with their own standards of care when it comes to rare kidney diseases. I do know there's only 300 nephrologists in the country that actually understand the rare kidney diseases. So you have your nephrologists that get kidney disease writ large, but again, it's not something that is extremely known. I mean, that's why they're considered rare kidney diseases. But you know, when there's over 150 diseases, there's also a lot of variance in terms of what people's symptoms might be, what you should be looking for. I went to a conference recently and they were talking about APOL, and I know Dr. G had mentioned this earlier about his son, and I found that everybody has APOL. It's just a matter of, do you have two? I can't explain it to you because you people are far smarter than I am, but just suffice it to say, everybody has APOL. And because of where you're not genetically, where you came from geographically, you may have specific conditions passed on from generation to generation that allowed you to survive where you were geographically, that might hinder you today, because that APOL, the second APOL, was designed to protect people under certain circumstances. But
Real
now,
quick, could you tell us what APOL, because some people
what
may
it
not
stands
know
for?
what it, yeah, what does it
That's
stand for?
a
Some
Dr.
people
G
may
thing.
not
I don't
know.
even know what the actual words are because they're big words.
Oh, wow. So it is a
See,
papilloproteinurum L1, which is a rare genetic predisposition that was found over 5,000 years ago, originating out of West Sub-Saharan Africa. So during the transatlantic slave uh, journey, APO1 was actually brought from West Africa over to not just the United States, but to the Caribbean areas as well. So how this works, so each person, irregardless of your ethnic background, has an allele. Woman has one allele, the father has an allele. So how you can tell if you are positive. So the alleles are G0, G1, G2. So if you are like G0, G0, you're good. If you're like G1, G2, as my son was, he tested positive, which there are a number of rare genetic predispositions like Lord, I'm gonna butcher this word, but it's vocal segmental glomerular syndrome, FSGS. Then there's IgA nephropathy, lupus nephritis, and a whole host, HIV, attributed kidney disease, as well as hypertension. So really the difference is kidney disease, diabetes is the #1 cause of kidney disease. So the bulk of the folks in the United States lost their kidneys because of either diabetes or a combination of diabetes, hypertension. With APO1, again, which is a rare genetic predisposition, is mainly those that are hypertensive. And this can be certainly come down through generation and generation. So the only way that you know that you may have this is through a genetic test. And a lot of physicians are not willing to do genetic testing. So there's an organization that you can actually go through to try to get a free genetic test so you can find out if you are positive for APO1. But now here's the interesting thing. So African Americans, people of African descent, Afro-Caribbeans, Afro-Latinos are the ones that are at risk. APO1 is in 13% of African Americans, which is interesting because African Americans make up 13% of the population of the United States. So it can go undetected again, but you really need to get that genetic testing. So there's a lot of information on it. There's a number of organizations that are actually trying to work on a solution, but right now there is no cure for APO1.
So I have a question. I love the way you described it, and it's inherited. And as you said, it came from Africa, and that would explain. We have so many dialysis centers, mostly in minority neighborhoods. Have you noticed? So I guess my question would be eligibility, Mr. Eric. What is the eligibility? Because some people may not meet that criteria. They might be right on the cuffs where maybe their income, they are at a certain income bracket. Tell us again about the eligibility to receive the services of American Kidney Fund.
Well, for the, so for the financial assistance program, the eligibility is up to 500% of the federal poverty level income. And you can also have assets up to $30,000. So you can still have your savings. We don't hold that against you. And then you can also still have your retirement savings, your IRAs and things like that. That's not considered part of the calculations. If you find that you are over that, the only thing I would suggest is that you still contact our office. so that someone can actually go through and make sure that the calculations have been done correctly. Just to make sure that if there's some opportunity for you to get some resources, we want you to have those, rather than to just assume that you don't meet the criteria and then walk away. If you are under that, I mean, a lot of places you would be qualifying for Medicaid and Medicare, probably.
Mhm.
In many locations, at least before. Some states are, I know when it was time to renew for Medicaid, they started pulling people off the rolls. But again, make sure that people check with their local Medicaid office, and then they can also contact us. But if they know that they have end-stage renal disease, they automatically are qualifying for Medicare. And it's just a matter of, can you find the care that you need with Medicare? And if you cannot, then you should reach out to American Kidney Fund. And if you're having trouble doing that on your own, you can reach out to your renal health professional, and they should be able to reach out to us as well.
So I have a follow-up question. What if someone's in the, like you said, they have no resources, like the young lady, you said American Kidney Fund was able to raise the funds for her to have dialysis. There she was, kidney disease. What would be the cost of dialysis? I mean, I noticed 3 days a week, but what would be a rough estimate of, because this is a lot of funds. How much money would someone have to come up with, or organization would have to pay to help someone get started?
That is a question that I do not have the answer to, because we
Okay.
always recommend that it's covered under insurance, because it's not just an issue of dialysis, but there's also medications you may need,
Right.
and you still need to see your doctor. So if somebody's paying for all of that out of pocket, that's got to be an enormous cost, and it's something
Yes.
that's untenable. And if you have kidney disease, you may be trained as a whatever. It's likely that you will not be able to continue doing that work if you have advanced kidney failure, because you have to be in dialysis, and most employers are not going to understand that you have to be in dialysis for a long period of time for at least 3 days a week. So many people have to be in forced retirement, or they find that they're working part-time jobs, or just not able, in many cases, to use the skill sets that they've worked all their life to develop.
Yes, that's the sad part about it. And I'm sure with American Kidney Fund, do you guys have a support group for people in that space who can no longer work full time? Are there support groups available for people with kidney disease? Do you know?
The only support group that we offer at this time is through our Facebook group. So it's a community of people who face similar issues. They have the ability to interact with one another, with or without our input. We also have monthly ambassador update calls, where we try to share some information that they say that they want us to provide to them. And then there's a period where they can just talk off the record about whatever is going on in their lives.
Okay, that's great. The floor is open. Is there anyone in the audience that have any questions? Because this is a phenomenal presentation, sharing the specifics of how this is it actually is inherited, and this is probably something new that all of us are learning for the first time. And to know that we have such an organization that will give funds not only to a person with kidney disease, but also to organizations, so that the organizations could go out in the community. Could you talk about that a little bit, Mr. Vicks?
Um, is it okay if I first address Dr. Gaddis's
Sure,
comment?
sure.
She's asking about what specific efforts are on the way to engage Black and Hispanic men in the prevention of kidney disease. So
Yes.
we are starting to do, like I say, our health equity discussions, which are targeted to people of color, and depending on the location, some of them are targeted towards African Americans, some are African American and Latino as well. Just depends on the location. But we haven't specifically tried to size out men. It's just trying to get the community together at all has been the challenge. Trying to get people to the table and help them understand. In my previous experience working in community engagement in healthcare, we tend to target the women in the lives because the women we do find can express these same issues to the men in their lives and try to get them to the table, try to get them to the doctor. So if they can't get them into the room to talk to me, I would prefer if they can get their significant others, their brothers, fathers, to their doctor. So that's where we have been putting our energies, but we will be looking more and more at how to get specifically men to the table, because that has been a difficult situation in terms of getting them into care at all. Now, you had mentioned some programming that we have to get, I'm sorry, Dr. Gaddis.
Oh, I'm sorry. I just want to lift up the fact, as you can see, I have no hair. And, the person that I see most frequently is my barber. And on any given day, if I come in, I kind of push the envelope and get these men in this barbershop to talk about things that they traditionally would not have a conversation about, to a point where if I come in, they say, what's the topic of the day? And so I just believe that to assume that there are not men that are not in a relationship, that don't have a steady main partner, who don't have that female influence on them, I would suggest that there's a large number of those kinds of men, and that there's opportunities that we might be missing in male-centered spaces to really take this information. That I want to acknowledge Francis Ash Goings, who's the reason why I'm on this call. I think as I listened to you and the information, it was long overdue, with all the interconnectedness with health disparities. And so this has been very enlightening for me, as well as pushing me personally to be thinking about what I need to be doing with a dad who was a diabetic and a father-in-law who is currently in dialysis, to rethink what I'm saying, why I'm saying it, and who I'm saying it to. And so I just really want to thank you for this. Thank Francis for inviting me, Dr. G, for his story to help us reflect on why we're in this space right now. And I just look forward to participating more actively in a place where I have not been.
Now, Eric, can I trouble you 1 second?
Please,
Dr. Gaddis, now, I don't know if you remember me.
I remember you.
Oh, okay. So, yeah. So, first of all, thank you for your work that you're doing in HIV prevention down in South Carolina. So, through Trinity and Project Tech, we did, I believe last year,
we did
a men's health summit, as well as a diabetes support group. But of course, just like Eric said, one of the biggest issues, especially with Black men, is that when you are presented with a chronic illness, it's another thing on the plate. And men are very prideful, and we don't like to deal with things that's going to hamper us from taking care of the family. I don't know if this is a generational thing. I can tell you, with the G's that are in South Carolina and me being in Virginia, it's a hereditary thing. And I was a little bit hard-headed myself, because even though I didn't know my symptoms, I knew that something was wrong. But I felt like I needed to go to work. I needed to provide. I had kids to take care of, stuff like that. So I do know that throughout the country, there are certain barbershop initiatives where they use barbers as well as beauticians to talk about diabetes. hypertension, cardiovascular disease. I do know that NIDDK has a program called Kidney Sunday, where it's kind of like a roadmap to where you can go into particular churches, take about 20 minutes to talk about kidney disease, and then afterwards they would do a number of tests on any congregants that want to be tested, as well as the American Kidney Fund going state to state talking about health equity. So if the men can be there this Saturday just to hear about the disparities, Dr. Gaddis, I know that you're familiar with the 29203, where you talk about the
I do.
diabetes amputations and the numbers in that particular zip code of dialysis centers. Just in that zip code, 9 dialysis centers in just that one zip code, catering to 41,000 residents. We do need to get men out there. So,
well, you know, if I may make this final
yes, ma'am.
comment, one, the resources that American Kidney Fund has available certainly is provoking me to get access to some of that, so that I can introduce some of that to in my barbering space, and talk to my barber who has many linkages or social networks with other colleagues about what we can do to spread the good word. Many of us are caregivers and people who have to transport folks to their, and I think that's rarely addressed. Frances has, watching her journey over the past years, says that it's not just the client, but it's the people who love and care for folks that also have to be supported. And I think there's opportunities for that as well. But in closing, what the thing that really compels me and what I'm really struggling with around primary care is we tell people to get it in South Carolina, where we haven't even expanded Medicaid. So, but that being said, I talked to a doctor level person the other day who was at his cardiologist, and it was through his heart concerns that his cardiologist questioned his PSA, only for him to find out he had 4th stage prostate cancer. And so I am really struggling with this primary care model. How is it that so many people are walking into 3 and 4 stage events when they go to the doctor maybe once a year? What's missing? Are we not? Are primary providers not taking blood? Are they not looking at A1Cs? Are they not using that one opportunity where that person presents to do a comprehensive analysis of their hormones and their blood and everything else? And so it tells me that this is critical about creating literacy and teaching people not to be afraid to question authority, to that they should be walking into spaces with this kind of knowledge, demanding, not asking permission for, but demanding that their physician either give them these tests or I'll find another physician.
Wow, thank you so much, Dr. Gladys. Thank you so much for sharing it. And now that we're trying to wrap everything up, I just want to say thank you to our guests, Mr. Eric and Mr. G. You guys shared so much enlightening information. And the takeaway from this would be everyone, each of our organization, we are NBNA strong. Every single organization, we need to have some type of grassroots effort where we're getting the information from the American Kidney Fund and taking it back to our communities, because as Dr. Dawson said, prevention is key. Health promotion and prevention. And that is what we need to be doing. And I will be reaching out to you, Mr. Vick, so that I can get that information in the Jacksonville community. But Education is key. Any final words from Mr. G and Mr. Vicks before we close this out? Normally we end at 1 p.m., but any final simple words, starting with Mr. G first?
I just want to thank everybody for being here to talk about such an important topic. And anything that I can do along with the American Kidney Fund, just please reach out and let me know.
Thank you. Mr. Vicks, final words, please.
I just would like for everybody to try to stay engaged as much as possible. Again, thank you for this opportunity. Please text the word kidney to 52886 to join our network, and we can make sure that you get all the information as it's coming live.
All right. Thank you, everybody, for joining us with Wisdom Wednesdays. We have upcoming events coming up, and we will be sharing the information all the way up to December. Thank you, and have a great rest of your day. Goodbye, everybody.
Bye.
Goodbye.
Have a good day.
Goodbye.